All right, well, thank you guys for coming. We are going to do an exam 2 review to help you guys get ready for later this week. So this is, if you, these cartoons make me laugh. So that's the poor liver trying to talk about including iron in your diet. And that's the tongue asking for ice cream. So you guys need to laugh. So jokes. Okay. Okay, so let's jump right into thrombocytopenia. So what's the problem with thrombocytopenia? Yeah, so if you don't have enough platelets, what happens? Yeah, yeah, yeah. So where can you bleed? Like, how would we know that a patient is bleeding? Yes, so GI is one that's really common, right? Gums, right? That's another one. You could have bruising on the skin. So GI bleeding, how's that going to show up? Yeah, so you can have frank blood in the stools, you can have black tarry stools, you can have hematoemesis, right? Did somebody say GU? So like blood in the urine? That can be a problem. And then you get all the like the petechiae and the purpura and all that stuff. Where would be a really dangerous place to bleed that doesn't do well if it bleeds from there? Yeah. So what happens when you bleed from your brain? Well, it's bad, right? Like you can die from your blood brain. Yes, stroke. Yes. But it presents often as really bad headache. It can present as like deficits, right? Like in a typical like ischemic CVA. So yeah, bleeding in your brain is bad, and that's something that can happen when you have not enough platelets. We talked about that. What other disease process that we talked about on for this test is at risk for bleeding? And for the same reasons. Yes, so who gets varices? Yeah, so your liver patients, right? They're at risk for bleeding. Because remember, your liver's in charge of clotting factors. Teaching. So make sure you know what you're teaching for thrombocytopenia. What's the big thing for teaching for thrombocytopenia? Yes, you want to avoid IM injections, but safety measures, right? Don't fall and hurt yourself. Don't hang Christmas lights on the roof. Like every year, we would get like it was always like sorry dudes, but like it's always like an elderly gentleman who's on his blood thinners who would be up on the ladder trying to put Christmas lights on like the second story or something stupid of their house, and he'd fall off the ladder. So, anyways, every time. And then things like preventing constipation, soft tip bristled toothbrush, blow your nose gently, those kind of things. So let's do a practice question. Nurse is creating a teaching plan for a client who has thrombocytopenia. Which of the following instructions should the nurse include? Select all that apply. What do we like A? Yes. Yeah, you could put some, you don't want dry, cracked lips, right? A's all right. We can do that. Brushing teeth with the soft bristled toothbrush. Yeah, that's a good one. We already talked about blowing our nose gently. What about D? Do they need to limit their fruit consumption? No. they do not. What about using a straight edge razor? Do you guys know what a straight edge razor is? Yes, use an electric razor, yes. So I included a picture because a straight edge razor is like a blade on a stick. This is a straight edge razor. So it's like a blade to shave your face on a handle. Do you think you want your patient with thrombocytopenia trying to shave with one of these bad boys? Yeah, so think like hipster barber or like old-timey barber, what they used to shave with, or like if you're trying to be cool these days and you like actually go to a barber that does this kind of thing. That's, yes, exactly, yes. Sweeney Todd, that's what I think of too. Like that's how Sweeney Todd did all of his damage. If you haven't seen Sweeney Todd, it's extremely dark in kind of a funny way. I don't know, it's a very weird musical. Okay, but yeah, you don't want your thrombocytopenic patient using a razor on a stick. Okay, so neutropenia. What's the problem with neutropenia? Not enough what's? Yeah, they don't have enough white blood cells. Because they don't have enough white blood cells, they're at risk for infection, right? Because that's the job of your white blood cells. So neutrophils are the particular type of white blood cell that we measure, right? So what does it matter if you don't have the ability to fight infection, right? So high infection risk, and what do they tend to get? Fever, yes. But do they, let's talk about fever for a second. When they get a fever, do they get a high fever? What's a neutropenic fever? Low grade, right? Yep, doesn't have to be high to be significant. So even a low grade fever is going to be a medical emergency for these folks, because what happens when they get sick? What can they quickly progress to? Sepsis, yes. And then what happens if you get sepsis? You're at high risk of death. Yep, sepsis and death. So I always want you to pair those together because I want you to understand the severity of sepsis, especially if you don't have any ability to fight off an infection like you should. You just don't mount the same response, right? Blah, 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 blah. So you would check any place that you could get an infection, right? Make sure that you know what neutropenic precautions are. So what kind of special precautions do we follow for people who don't have sufficient neutrophils? Yep, yep, yep. Especially in pandemics, it's like a whole thing. But that's why they don't allow flowers in the ICU, right? Because you've got people who are immunocompromised. If you didn't know that, don't buy flowers for your friends and loved ones in ICU. They can't have them. Okay, a nurse is planning care for a client who's being treated with chemo and radiation for metastatic breast cancer who has neutropenia. The nurse should include which of the following restrictions in the client's plan of care? A, B, C, or D? What do we think? So we put D in there to make sure you knew what neutropenia meant, right? Neutropenia doesn't have anything to do with bleeding. Right, it's B, right? No potted plants, no fresh flowers. That's part of your neutropenic precautions. It's for A, you can have visitors. They need to wear a mask, wash their hands, and they can't be sick. So it's not that they can't have visitors, but you just need to make sure that you have healthy visitors that are following the rules that they need to. So what is the underlying issue with your anemias? Like at the very most basic thing, why does anemia matter? Yeah, it's low red blood cells, but what impact does the low red blood cells have on the body? Yeah, so you're getting good oxygenation or tissue perfusion, right? Because you don't have enough cells to carry the oxygen where it needs to go, right? So at the heart of it, that's the underlying problem. So there's lots of different types of anemias. So an iron deficiency, you need to make sure that you know what iron containing foods are, right? Because that's how we treat iron deficiency anemia. Is a lot of times dietary. You can give iron supplements, of course, but make sure that you know what foods have iron. Aplastic anemia. So what's wrong with aplastic anemia? Ooh, do y'all know what aplastic anemia? All the cells, right? So your white blood cells, your platelets, and your red blood cells are all insufficient amounts, right? So they can have like every complication. So just, you don't want to wish aplastic anemia on anyone because it really stinks. So all the teaching that you would do for the individual types, you need to do for your aplastic friends, okay? Pernicious anemia. Make sure you know details around pernicious anemia. What causes pernicious anemia? What treatments do we have? What assessment findings would we have? Right, so there's particular people who are at risk for pernicious anemia. Make sure you know that. And what's the deal with treating pernicious anemia? Yeah, can you take oral B12? Yeah. So that's something that you need to know, right? Because it's a whole intrinsic factor thing. We can either do infusions or nasal. Because if we don't have the ability to absorb it, it doesn't matter how much we eat, it still won't get absorbed. So anyways, hemolytic. So remember, hemolytic is a little special. It's where your red blood cells are getting destroyed. And so there's some particular signs and symptoms that show up with hemolytic that don't show up with your other anemias. Like what? Jaundice is the big one, right? Because it's this destruction of, yeah, and you can have pain too, like when we're talking sickle cell. So when you have this destruction of your blood cells, the bilirubin gets released. So that's where the jaundice comes in, okay? Cool. Sorry, my munchkin is crying in the background. You guys should be used to that by now. Okay. A nurse is caring for an antepartum client. So that means somebody who is still pregnant, who has iron deficiency anemia. When teaching the client about nutrition, the nurse should emphasize the need for an increased intake of which of the following foods? I know. I do too. Poor baby. Right. It's like, okay, pregnant woman, go eat some liver. Which just sounds terrible. But go have a steak. Eat some, yeah, you can do liver. Eat some spinach. Spinach has iron in it, right? Like dried fruits, I think. Liver would be the last thing I would want to eat. Just saying. Okay, a nurse is reviewing a client's lab results and finds the hemoglobin is 10 and the hematocrit is 30. The nurse recognizes that the client is at risk for which of the following? So a hemoglobin of 10, is that enough? Nope. So they've got a low hemoglobin. What about a hematocrit of 30? Do you need to know these lab values? Yes. So is it A, prolonged bleeding? Do hemoglobin and hematocrit have anything to do with bleeding? Nope. Cellular hypoxia, do we like that? Yeah, it's an anemia, right? So they don't have enough oxygen carrying capacity. Let's go through the other one. Impaired immunity, what is that? That would be like neutrophil counts, right? Yeah. And then fluid retention, that's right out. Now you're just making stuff up. That would be like an albumin level, right? Or if you've got a high BNP or something like that. If we're talking like heart failure. So we've got a post-op person with anemia because they lost a lot of blood in surgery. Which of the following findings should the nurse expect? So whenever you're talking about blood loss anemia, if you've ever donated blood, I always like compare my experience of donating blood to blood loss anemia, or any of the anemias really, because it's all kind of the same problem, a different cause. But if you've ever donated blood, how did you feel? So hypertension doesn't make any sense, right? If anything, they would be what? Not hypertensive, but Hypotensive, right? Bradycardia. Bradycardia also doesn't make sense. If they've lost blood, what's going to happen to their pulse rate? It's going to go up, right? Diarrhea, not really in the same ballpark. So fatigue makes sense because they don't have the same oxygen carrying capacity, so they're going to get fatigued. So anytime I donate blood, I have to like go home and take a nap. And also like sit on the couch for, I don't know, maybe a day or 3. So it's like a whole thing. Which of the patients just arrived to the ED should the nurse assess first? Ooh, I love these types of questions. Okay, a patient who reports several dark tarry stools and a history of peptic ulcer disease. So if I have dark tarry stool, how quickly am I bleeding with my history of peptic ulcer disease? Yeah, that's a slow bleed, right? So is that going to be my priority? Nope. B, warfarin experiencing a headache after a fall. What do we think about that? Yeah, that's no bueno. Let's go through the other ones. Pernicious anemia, paresthesias to the hands and feet. Expected, right? That's not anything that worries me. That's not going to bump them to the top of my list of people to see. D, chemo needs a scheduled blood transfusion. What's the operative word in that sentence that makes it not important? Scheduled, right? Routine, planned. None of those are ever going to be a priority, okay? So we're worried about a brain bleed for our patient B. They're on a blood thinner and they fell and hit their head. So that would be of your ABCDs, that would be your D disability. Okay, a nurse is teaching a client who has a new diagnosis of aplastic anemia. Which of the following information should the nurse include in the teaching? A, aplastic anemia is associated with iron. Is it? Nope. B, aplastic anemia results in an increased rate of RBC destruction. Is that true? No. Which anemia is RBC destruction? Yeah, however you spell it. Yes, hemolytic. C, aplastic anemia results from an inability to absorb B12. Also no. Which anemia is that? Yes. However you spell that word, yes. So D, aplastic anemia results from decreased bone marrow production of RBCs. Do we like that answer? Yes, it's a bone marrow problem, aplastic anemia. That's why all of your levels are low, because the problem is at the bone marrow where everything is made, okay? If you don't know that, go learn that. You got a little time. That's why I try to do these reviews a little bit ahead of time so you can go back. The nurse is planning care for a client who has pernicious anemia. What are we going to do for them? We already talked about this. What's the answer? Thank you. I put so many anemia questions on here. Bless it, bless it, bless it. Okay. Sickle cell. Know how to assess your sickle cell patient. Muy importante for you to understand the treatment of sickle cell anemia. What do your sickle cell patients need? They need a handful of things, and they need them quickly. They need oxygen, yes. What else do they need? Pain medications, IV pain medications, narcotics, right? What else? Fluids, right? All of these things are going to help reverse the process. So they're going to prevent continued sickling. They're going to prevent these cells from being so stuck together and lodging in all of these small vessels, right? And then what is the thing that most often causes these, there you go, the thing that causes these episodes of sickle cell crisis? So Cynthia said it, infection, right? So we need to find out if they have an infection somewhere. Also stress and dehydration too, for sure. and high altitudes. But we want to make sure that they don't have an infection somewhere. So we're going to do some cultures of some things to make sure that they don't have like a UTI or like an upper respiratory something. Prevention of crises, make sure you know how to do that. And then understanding the complications, right? There's that picture. I think I put it in here. Yeah, there's your picture of all the things that break from sickle cell. So this is copied and pasted from your book. So lots of things can happen with sickle cell. So spend some time making sure that you understand all of those complications and why we so aggressively treat sickle cell. Okay, patient who has sickle cell crisis admitted with vaso-occlusive crisis reports severe abdominal and flank pain. Which analgesic are we going to give them? What do you think? Yep, IV narcotics, right? Transdermal patch doesn't work quick enough. Ibuprofen is just mean. Liquid hydromorphone, you don't want to give liquid when you can give IV. Okay. Nurse is assessing a child in a sickle cell crisis. Which findings should we expect? So remember when we did that case study, it was pain that they assessed for. That guy wound up not being in a sickle cell crisis, but yeah, pain is one of the hallmark symptoms because you're getting all of those occluded vessels, which causes ischemia, which causes pain. So you're going to definitely assess for pain. Nurse is creating a plan of care for somebody with sickle cell. Which of the following interventions should the nurse include in the plan? So A, discourage high level of fluid intake? No, we want them to be hydrated, right? What's wrong with cold compresses? You're good. You are welcome to say the wrong answer. Yes, so it's going to make it worse, cause more vasoconstriction. So we want to do warm compresses. Observe for hypokalemia. So it actually is that, because as they start losing electrolytes and stuff, as we get them hydrated, that becomes a problem. Oh, I was going to take this question out. I kind of hate it. So you do have to watch for hypokalemia just because you're hydrating them. And so you can have electrolyte imbalances from that. I need to switch this one. And so D is meperidine. It's like Demerol, and it can cause seizures. So we don't give Demerol anymore. We used to. No, you're good. But yeah, okay, so let's move on to blood transfusions because there's like 10 questions on them. I don't know if you guys saw that on the outline, so you need to know something about blood transfusions. It is C, yeah. Watch for electrolyte imbalances. Okay, so ABO compatibility. There's some charts that you can use to figure out ABO incompatibility. So O negs can receive or they can give blood to anybody. AB positives can get blood from anybody, and then it kind of breaks down in between all of that. So make sure you understand that. Okay, who can get what? There's some different rules for platelets and other products about who gets what, so don't even worry about that. Just for blood is what you need to know about compatibility, okay? Know the complications. Yeah, I know it gets kind of like off in left field, so don't even worry about them. You've got complications of fluid overload. You've got allergic reactions, febrile reactions, and hemolytic reactions. So make sure you understand all of those. TRALI, that's the transfusion-related acute lung injury. How would we know if somebody is in TRALI? So it's acute lung injury. So what might there be a problem with? Yeah, breathing, right? So they're going to have some kind of respiratory something if they're having TRALI, right? If they don't have respiratory symptoms, it's probably not TRALI. So yeah, dyspnea, crackles, they're going to have anxiety, respiratory distress, okay? What do you do if your patient has a suspected transfusion reaction? You need to know this. Stop the infusion. And there's other things that you do, right? What else do we do? Get some vitals. Yes. Tell the healthcare provider. Yes. We want to give them some IV fluids. Yeah. We want to get a urine sample and a lab sample because we're checking for hemolytic anemia, right? If we did like a ABO incompatibility, we'll have the lysis of the cells that happens, right? So we want to check for a hemolytic reaction, so that's why we get a urine sample. Yeah, we don't want to give them anything else. We send the bag and the tubing to the lab, that's right. Give them some oxygen. We want to notify the blood bank too. They get worked up about those sorts of things, as you can imagine. And sometimes the provider's like, just keep going. And you're like, oh, okay. Yeah. So you're administering a blood transfusion to a patient. Which action can the nurse delegate to the unlicensed assistive personnel? This is a fun one. What do you think? Yeah, they can do some vitals. Can they do your independent double checks? No, those are 2 nurses. Are they going to assess your patient like in C? No, that's your job. Is it their job to make sure the blood goes in within 4 hours? No, that's your job too. Right. Nurses providing orientation or giving some packed RBCs. Which action by the new nurse requires immediate intervention? Which one is the new nurse messing up? Yeah, it's C. You only give blood with normal saline ever. If you give it with D5, it can actually like damage the cells. Fun fact. Nurse is assessing somebody getting a unit of packed RBCs. The nurse report or the client reports chills, back pain, blood pressure goes patooed. Which of the following actions should the nurse take first? Stop the transfusion. Right? Okay. The nurse is caring for somebody getting a unit. 15 minutes after the start of the transfusion, the nurse notes that the client is febrile, chills, red-tinged urine. Which of the following transfusions reactions should the nurse suspect? Red-tinged urine. Yeah, right? Right. The red-tinged urine is hemolytic. That's why you get red-tinged urine, because you're chewing up your cells. Make sense? That's the defining characteristic. Okay, we're going to move past that one. Peritonitis. We're finally to GI. Okay. What can cause peritonitis? Like everything that we learned about in the last module 6 and 7. Yes, ruptured appendix, gallstones, sure. What else? I don't know what that means. Ascites, yes. Trauma, What about peptic ulcer disease? If they perforate, right? There you go. We were on the same wavelength. Sure. Indirectly. Like you can get there because alcoholism causes everything, right? It's like a risk factor for everything. What's the one organ that's secretly trying to plot your demise? The pancreas, right? Pancreatitis. You can perforate your pancreas in trauma. Signs and symptoms. What is the big one? That's never normal, no matter how many crunches you do. Abdominal pain and rigid belly. Rigid bellies are not normal. And usually it's sharp, yeah, board-like abdomen. If I ever say rigid board-like abdomen, it's problems, right? Knees flexed is the most comfortable. We're going to treat their pain. We're going to keep them NPO, right? What else do we need to give them very soon? Because they're at risk for this complication with their peritonitis. Antibiotics, right? So because they're at risk for what? Yes, infection leads to sepsis, which leads to, thank you. So yes, they can have sepsis, they can have abscesses, they can have hypovolemic shock. They can go into ARDS, acute respiratory distress syndrome. There's a chart in Lewis you should take a look at that lists all these complications out for you. But peritonitis is bad news, okay? That's the complication for all of our things GI. So make sure you really understand it, because that's like the worst case scenario, right? Client underwent an exploratory lap, so they kind of like opened him up and poked around. The healthcare provider should be called immediately for which physical assessment finding. That one's too easy. You're not going to get questions this easy, by the way. Don't be lulled into complacency. Yes, right. But in the review, the questions were so easy because I'm trying to jog your memory. Billroths. Make sure you understand Billroths. Who gets Billroths? Why do they get Billroths? What are the complications of Billroths? What's the dietary drama associated with Billroths? What kind of patient teaching do you do with Billroths? Know about the Billroths in all of their Billroth glory. We're not going to talk about it because we have other things to talk about, but review it. Nurse is providing teaching to a client who's pregnant and is vegan. The nurse should instruct the client that which of the following foods is a reliable source of vitamin B12. Because people with Billroths can have anemia problems, right? Because they lack what? You are correct. It is B. Because we get rid of portions of their stomach, right? When we get rid of portions of their stomach, what happens? They lose what? That can cause their pernicious anemia. Intrinsic factor, right? Like Hughes, you're asking us to type things that we don't know how to spell. Sorry. You're saying it like on your end, right? Even if you're not typing it. No, you're totally good. I realize that I'm asking you like really difficult things to spell quickly on the fly as I'm impatiently waiting for your response. If we were in person, this would be so much more fun. Okay, peptic ulcer disease and gastritis. What are the types of, or the reasons why you get gastritis? Like everything can cause gastritis, right? Including alcohol and smoking, because everything causes, or alcohol and smoking causes everything. Know the complications, patient teaching of peptic ulcers and gastritis. How would you know that the patient had the complication? So remember with your gastritis, it's things like NSAIDs, alcohol abuse, bacteria, viruses. The complication can be anemia. We can give them coalbumin. Peptic ulcer disease, complications are perforations, hemorrhage, hypovolemic shock. They can get gastric outlet obstructions. And then we just want to avoid foods that cause the pain. We give them meds. If they've got H. pylori, we give them antibiotics, right? Nurse is caring for somebody with peptic ulcer disease. Which finding is the most serious? I feel like I'm making this easy for you guys. I'm trying to drive this point home. Yeah. Yeah. So coffee ground emesis. Let's talk about coffee ground emesis for a second. Is that a fast bleed or a slow bleed? It's slow. It's slow because it has time to digest. That's what makes it coffee ground. Digested blood looks like coffee ground, so it's been sitting in the stomach and starts the digestive process. Okay. Bright red blood that gets vomited is like a quick bleed. Yes. Make sense? And then peptic ulcer, like they always have burning after they eat, right? That's like part of the whole disease process. So that's not the right answer. But perforation is D, right? So that's why it's a problem. Okay, nurse is assessing somebody with peptic ulcer disease, which is a priority finding. Which one makes us most worried? Yeah, so we just talked about that, right? We're vomiting bright red blood. That's no bueno. Because that's a fast bleed, not a slow bleed. Again, peptic ulcer disease. Which findings should the nurse recognize as a risk factor for this condition? Yeah, NSAIDs. They really tear up your gut. And people think you can take them like candy, but you cannot. There are consequences. Make sure you know your diagnostics. This is good use of your ATI book. So we can do CTs. Endo is going with a scope from the top. Colonoscopy is going with a scope from the bottom. So make sure you are familiar with those, how you might assess somebody who's recovering from one of those procedures, because that is like a moderate sedation. So they don't put them completely under, but they are to where they don't care and not aware of what's happening. TPN. So who gets TPN? Like, why might somebody qualify for? Yeah, so they're NPO for whatever reason. Yeah, so they've got dysphagia, or they've got a perforated, peptic ulcer disease or peptic ulcer or something like that. And we give it through IV, right? How would we know that our TPN is working? Yeah, so lab work. What else? What's the whole purpose of TPN? What are we trying to give them? Yeah, weight gain would be something. So signs of good nutrition, right? Like wound healing appropriately, skin integrity is good. Yeah, I like that one. Complications. So there are complications of TPN. Make sure that you know them. They can get hyper or hypoglycemia. They can get pulmonary edema, right? If we overload them with fluid, just like any other fluid that we give people. Appendicitis. Why is appendicitis a big deal? Why do we care? Why do we have to do emergency surgery? If it ruptures and we get sepsis, and then what happens if we're septic? We can die. And that would be super lame to die from your ruptured appendix. Okay. What is a thing that we would worry about in our appendicitis patient if they had all of a sudden what? Yes, their pain all of a sudden gets better. Oh, I feel better. Can I go home? No, you cannot. Okay, the liver. Let's talk about the liver. Okay, so I know that it didn't break down specifically hepatitis on your outline, but hepatitis causes cirrhosis. So you need to know about hepatitis, okay? What causes hepatitis? Different things, right? It's not just alcohol. It can be caused by viruses. There's like A, B, C, D, elemental P. There's lots of them out there now. But A, B, and C are the ones that you need to know about. How do you get those things? Who's at highest risk of getting the various hepatitises? How do we prevent them? So like good hygiene, getting vaccinated, don't make poor life choices. There's specific labs around hepatitis. What are some of them? Anybody know what labs we? Yes, AST, ALT. Yep, those are our liver enzymes, right? What else? What else do we look at? What else is important with hepatitis? And cirrhosis. Albumin. Yep, very good. And then what's something that breaks, what your liver breaks that we worry about? That's a lab. Clotting factors, right? So signs of bleeding, PT, PTT, INR, we want to check all those. Know how somebody with acute hepatitis would present, like what kind of signs and symptoms they would have, versus somebody with chronic, how would they present? They've got some specific symptoms that they have. What kind of patient teaching would you do? Liver is involved. There's lots happening there. Okay, care of a client with acute viral hepatitis. Which thing can we delegate? There's going to be, I think, 2 delegation questions. It's always good to practice these because you guys get a little topsy-turvy on them sometimes. What about D? What's wrong with that? Can your unlicensed assistive personnel assess? No. Monitoring for dietary preferences. I mean, that's not really their job. If you've ever been an unlicensed assistive personnel, do you have time to play games with your client? That makes me laugh. No, they don't have time to play games. That's cute. I know. Wouldn't that be so fun? Like bust out some Skip-Bo. That'd be awesome. But A, right? They can do a bedpan. You would want to wear gloves regardless. It's just standard precautions, right? Nurses teaching self-management to somebody with Hep B. Which of the following instructions should the nurse include in the teaching? We talked about this a little bit in the case study too around patient teaching. Are they going to let somebody donate blood that's had Hep B? Nope. High protein diet. Do we want people with Hep B to have high protein? No, because that can be problematic, right? Because protein metabolism is a thing. Yeah, so C is our answer. Do you want your liver patient to take acetaminophen? For the love. No, thank you. Nurse is teaching somebody with Hep A about preventing transmission. Which strategies should we include? Never go eat fast food again. Yes, hand hygiene. Very good. Is hepatitis A passed through intercourse? Nope, not that one. The other ones are, but not hepatitis A. Cirrhosis. So same labs, right? What are complications of cirrhosis? You need to know those. What's the big nasty complication of cirrhosis that you need to know? Because it's the most lethal. So portal hypertension, right? So portal hypertension is the underlying thing, right? Yes, can cause ascites, can cause varices. Varices are what's going to kill you, right? Hepatic encephalopathy, that's caused by your high ammonia levels. Yes, very good. They can have bleeding issues. They can have spontaneous bacterial peritonitis from their ascites, right? Because you've got just fluid kind of hanging out in a warm space, which it can just spontaneously like be an infection. And then you have peritonitis, and then you get sepsis and trauma. Okay. The nurse is caring for a client with cirrhosis and portal hypertension. Which statement by the client is cause for greatest concern? So think about portal hypertension. Which thing could kill them? Think about what could kill them. What happens? So sitting in a recliner, if they've got a big old ascites belly, do we expect that? But that's not going to kill them, right? It's uncomfortable, but it's not going to immediately lead to their death. What about edema in their feet? Is that going to immediately lead to their death? It's uncomfortable, but no, it's not going to kill them. Buttoning their pants because of their swollen belly. Again, it's ascites, but it's not going to kill them. What's the problem with straining during bowel movements? What is that going to do? Yeah, so you're increasing the intrathoracic pressure, and you can actually cause rupture of your varices. Dun, dun, dun. You following me? Yeah. So we don't want them to be constipated. It's no bueno. Because they've already got that portal hypertension drama happening, right? Okay. Somebody with advanced cirrhosis, they have ascites, peripheral dependent edema, nausea, vomiting, dyspnea. Which indicator is the most reliable for tracking fluid retention? So they gave you lots of information, but then they just ask you about fluid retention. How do we track fluid retention? It's the same, no matter what's the problem. How do we do it? Yeah, daily weights. Nothing more complicated than that. But now we saw what a client with advanced cirrhosis has, right? Have all these things. They feel terrible. Absolutely terrible. Okay. Portal hypertension, hepatic encephalopathy. Because of their liver disease, they're treated with lactulose. What lab result? So this gave us lots of information about portal hypertension, hepatic encephalopathy, liver disease. They're getting lactulose. So they gave you lots of little tips. That's why I included this question, because it kind of hits all those points, right? Yeah, ammonia level. Because lactulose treats the ammonia, right? Okay. Somebody with cirrhosis, which is an expected finding? Yeah, they get those weird like varicose vein things on their bellies, right? Client with end-stage liver disease, talking to your nurse about being on the transplant list. I like this question. It makes me laugh. Which is the cause for greatest concern? You like say, what? Which one is it? If they have end-stage liver disease, do they need to be drinking alcohol? No. They should have stopped that a long time ago, right? Yeah, cut back. I guess I should cut back now that I have the need for a liver transplant. Bless it. I know you guys are being all like academic, talking about prescribed medications. Yes, that's a concern. But the greatest concern is that they're continuing to kill their liver with their alcohol consumption. Okay, hepatic encephalopathy. You need to know about it. What causes it, signs and symptoms of it, treatment of it, what labs do we do? Make sure you know it. We did a whole case study on it, so we're not going to belabor it any. But make sure you know hepatic encephalopathy. Varices. So we've talked about this a little already. What causes them? Remember, it's that portal hypertension. I talked about that in the lecture pretty extensively. Complications of your varices, you bleed out and die. Assessment findings. So how do you know you have ruptured esophageal varices? What's it going to look like? What are they going to do? Yep, vomiting blood. Yep, it could be coughing, sure. What about vital signs? What do you think? Hypotensive, right? And what about their pulse? Tachycardic, right? Those kind of pair together. Hypotensive, tachycardic, because it's your body trying to figure it out, right? We got late-stage cirrhosis with portal hypertension. Which of the following options below are complications that can develop from this condition? Select all that apply. Will you get a question this easy? No, you will not. Do they have an increase of albumin levels? Nope. They have the opposite, right? What about ascites? Yep. Splenomegaly. Do you get a big old spleen when you have Portal hypertension? Yes, and then it chews up your cells too early and you get drama. Fluid volume deficit. Do they get fluid volume deficit? They get overloaded, right? And then esophageal varices, of course. We already talked about that. Okay, moving right along. Pancreatitis. There's lots of causes of pancreatitis, right? You can look those up. What does it look like? So what are signs and symptoms of pancreatitis? What's a big one? Yeah, so your pancreas is trying to digest itself, so it hurts, right? How do we treat it? What's the big main thing that we do to treat our pancreatitis? For the love, keep them NPO, right? Pain meds, get them hydrated. We're going to monitor their blood glucose because pancreas is wrapped up in that. Remember, complications. So what are the complications? Like what area of the body has the most worrisome complications? They wouldn't necessarily associate it. Right, it's the lungs, right? So respiratory things. You're like, what? It's a pancreas. Yes, it causes respiratory complications. Like pleural effusions. They can get atelectasis. They can get pneumonia. They can get ARDS. They can get diminished lung sounds. Yeah. You can perf and get peritonitis. You can have an abscess. You can have sepsis. You can have a PE. You can have DIC. Hypocalcemia. There's like all sorts of nonsense that happens with your pancreas. Remember, it's trying to kill you. What labs do we look at with pancreatitis? Yes, amylase and lipase. If they're going up, then you need to back off of your, dietary whatever. If you're trying clear liquids and their amylase and lipase go up and they start hurting, then you make them NPO again. Also calcium. All right. Patient with acute pancreatitis, reporting excessive thirst, excessive voiding, blurred vision. What do we think's happening? Yep, don't forget, your pancreas is in charge of your insulin, right? So check that blood sugar. I like D. What? You're really thirsty, you have to go to the bathroom a lot, and you have blurred vision? Let's just turn the lights off. It'll be fine. You'll be fine. I'm totally ignoring you. Turn the lights off. Okay. CVA, TIA. So we just talked about this. So what are risk factors? Of course, diabetes is always a risk factor. Smoking, right? All those things that were risk factors for your heart disease are also risk factors for your CVA, TIA, right? Because it's those damage to the vessels. There's the 3 different types. AFib, right? That's a big one. Make sure you know the difference between a TIA and then ischemic versus hemorrhagic. What are your signs and symptoms? Right versus left. You don't need to know how to do an NIH stroke scale. I know you did that in your SIM class, but I mean, good information, but you're not responsible for that. By the by, because you came to the review, you get to hear this. Make sure that you brush up on cranial nerves. Just saying. I mean, don't spend hours, but do a little once over of your cranial nerves. Whatever little tools and tricks you use to remember them for your J1 checkoff might come in handy. Just saying. Remember, we always assess their swallowing before we give them aspirin. We do want to give them aspirin because of platelet aggregation, right? Making clots worse. You're welcome. We do an EKG to see if they've got AFib. Remember, we're trying to get to TPA. If they've got an ischemic stroke, we want to give them TPA, open that blood flow back up, right? We can do interventional radiology or a carotid endarterectomy. So you kind of go in there and rotor-rooter the plaques in their neck. Remember, there are complications associated with giving TPA. So make sure that you brush up on those, and also contraindications. Blah, blah, blah. Yeah, complications of hemorrhagic as well, and how you would manage all that. We're almost done. Nurses providing care for somebody with acute hemorrhagic stroke. The client's spouse tells the nurse he's been reading a lot about strokes and asks why his wife hasn't received Alteplase. Why are we not giving the hemorrhagic stroke Alteplase? Right, that's not how we treat hemorrhagic strokes, right? That's an ischemic stroke that we would give Alteplase to. So we would make her problem worse. So it's important that we get your patient to the CT scanner to determine if they've got a hemorrhagic versus an ischemic stroke, right? Because the way we treat them is very different. And time is brain. Okay, client with a stroke needs to be fed. What instructions are you going to give to the unlicensed assistive personnel? C makes me laugh. Feed them quick. Don't waste any time. What's wrong with B? Ooh, that ain't their job, no. If you're having to suction your client's mouth between bites of food, are they safe to eat? Goodness gracious, you should reevaluate your life. Okay, so sit them up, right? You don't want them leaning back. Make sure you sit them up straight. You eat sitting up straight, so sit your patient up. Nurse is preparing to give medication to a client with acute hemorrhagic stroke. Which prescription requires immediate follow-up by the nurse? What thing do you not want to give them? So they had a hemorrhagic stroke, right? Yeah, we don't want to inhibit platelets. They need those platelets. A 70-year-old client with alcoholism, lethargic, confused, incontinent. Wife tells the nurse that he fell about a month ago, but he didn't have a scratch on him afterwards. Which collaborative interventions will the nurse implement first? Yeah, so what are we going to look for? Yeah, so he's older, he's an alcoholic, right? That puts him at higher risk. And then he's got neuro symptoms. So it makes sense that we would go to CT scan, right? Make sure he doesn't have a bleed in his brain. All right, that was quick. Woo. All right, I like this. It makes me laugh, and it's inspirational at the same time. So I wish you all the best on your exam this week. I know that this is a stressful time for you guys, but just deep breaths, go spend some time in the sunshine today. It's beautiful outside. Even if you just take your notes under a tree. Make sure you're drinking water, getting some sleep. Don't have too much caffeine. You're welcome. And best of luck to you guys. You're welcome. Y'all have a great afternoon.